So welcome to the last seminar of this very busy academic year. Over the last months, we've been covering multiple topics, always around innovation and healthcare. One of the main was what did COVID change? What did we learn and how to better innovate in the wake of COVID? One of the main themes, recurrent themes, has been orphan drugs, how to both stimulate innovation and maintain accessibility. Then we also talked about digitalization and all the other tools. And today we are very happy to have Antonio Estache with us. So Antonio did his PhD here at ULB, but at the same time he was working at the World Bank. Being at the World Bank, he created massive infrastructure around the world, providing access to water, to electricity, sewage systems, and so on, with the problem systematically that you have to finance these things and sometimes involve the private sector. So at the time, I remember I was looking for the inequality impacts of these privatization schemes, and there was only one author who would focus on that, and that was Antonio. So since he joined I3h, he started venturing also in healthcare with this recurrent theme in mind. Today we'll be talking about is private equity good for healthcare, evidence and policy implications. Thank you, Antonio, for being here.
Thanks a lot for the invitation. Thanks to all of you guys for coming and to all of you guys who are on the screen. Let me just say a few things. I love color in PowerPoint, so I guess more to say. I have a bias. I'm being trained and I've been working for 25 years, mostly on policy and regulation at the World Bank, and then I started teaching about the same topics for about 15 years at ULB. And I did write contracts, I did work on contracts, I did negotiate contracts, so I have a good idea of what it means to work to interact with private equity funds. So a lot of what I talk about is driven by the experience in a field which is not health. But when I look at the health sector, I can see lots of things which remind me of the mistake that we've made, because we made lots of mistakes. And this is pretty much what I want to talk about today. The first thing that I think comes to mind is that you think about social, I mean, you think about water, right? I mean, if you don't have water, you die, right? It's social sector. I think it's quite important when you think about private equity that it's financial focus usually that people have. When you talk about innovation, we cannot afford to forget that you have a social dimension. And I'll talk a lot about that in this presentation. The trade-off between financial and political perspective when you're doing these sort of things. Investing in the hospital is not the same thing as investing in Volkswagen or but it's not the same thing. So there are a few things. There are lots of things we can talk about, but maybe I want to emphasize these because I feel more comfortable with them. Maybe I think it's quite an important question that we have at the table, and we have two sides to the table. The two sides of the table bring different perspectives. I mean, the policy perspective is very different from the one the deal maker has. And I think that sort of drives the way you think about these sort of issues, and certainly when you think about hospitals and you think about healthcare. I want to emphasize that in the presentation. One of the things that's different is the time horizon. I mean, I think in the long term, and private people want to think about how much money, how fast they make how much money. And that's a very different perspective. I think the way we think about it is that we want to add mandates. I mean, let's think about the social issue. So we talk about mandates and commitments to the long term, which have to be written in the contracts, which are not written in the contracts in the health sector. And most importantly, I think that everything I've read in the last couple of years on the topic is that people tend to think about specific deals, specific activities, but I think you need to have the health sector policy. The sector perspective and the deal perspective are very different, actually, and they imply very different things. They need to work together. They need to be joined. But ignoring one or ignoring the other one is just a stupid. The two things have to be taken jointly. So what I want to do is to sort of tell you what I understand when I read these papers. I will focus in hospitals and medical practices because you have lots of other people who've been working on that in biomed and stuff like that. And I want to emphasize that this started with a master thesis by a student of mine at Estache who worked in working finance these days. And we did lots of fancy econometrics that were very frustrating because the data was so bad that we only came up with basic correlations. But it was a year of work, and this is one of the reasons why I decided to have a closer look at the econometrics behind all the base conditions. We'll see where it goes. But again, I'm not going to put Greek letters, I'm not going to put fancy equations, I'm just going to give you the intuition today, right?
Oh.
But I have an annex if you want, I can go back to the equation just to make you happy. But this is what I'll do today. I want to give you the definitions and data and some overview of the things that I see in practice. I want to explain again quickly for those who are not familiar with it, but how the private equity game is being played. Then I go for my survey, and then I want to zoom on the social aspect, because that's what I care most about, I guess. And then I had a few ideas on the sort of thing. If I was still working for the World Bank and I was being assigned this file, there are a number of things which are no-brainers that people should be thinking about. And I think these are relevant for Europe as we can in a few minutes. And if we have the time, but it looks like we don't have the time, we're talking about what it means to Belgium, which is an odd country. I mean, it's an odd country in this debate because you don't have private equity. So that's one issue. So what's
So far?
Huh?
So far, so I think it is a.
Yeah, you're working on it? No. What's the again? This is very rough. It's on a few slides to make sure that we will have intuition on those issues. If any type of equity investment in an asset in which equity is not very liquid, committing for 3 years, the money that we have there, it's not traded publicly most of the time. And the idea is to manage the asset in a very commercial way. Okay, and then you sell it once you've made enough money on it. Historically, the commitment, when you look at the operators, was 10 to 12 years old, but increasingly, and certainly in the health sector, we're getting down to less than 5 years. So we buy, fix, and we sell. So the idea, but it's quite a sort of language for a guy like me. In infrastructure, when you amortize the road, it's 50 years. When you build a water treatment station, it's about 30 years. When you buy, I mean, these are long-lived assets, right? And so working with people who have an horizon of 5 years, when you know you have to maintain your assets for 30 years, it's a big deal. It's not very different for hospitals. Right? But so that you already have a sense of the kind of challenge that we have to think about. But at the same time, I mean, I'm the Minister of Finance. I have to pay for schools, I have to pay for health, I have to pay for pensions because people are living longer and they stop working. All of those things, so it adds up to a lot of money requirements. So I'm not going to speak for the potential for the financing. The trick is how I use it and how I work with the people who are willing to bring money on the table to make sure that I don't lose in the social objective that I have for myself. Okay, so we look at what it means in practice. So it's certainly something that we see in governments who are worried about the fiscal constraint. But again, I mean, this is my source of concern. So in health, it's interesting because you see that we have quite a number of deals in North America, growing number of deals in Europe, and quite a number of deals in Asia and Pacific. The coverage in healthcare, which is what I'm interested in, is quite large, but a big chunk of it is nursing homes, by the way. So that's part of the story. And what I see super cool, when you read the papers, you see you have specific paper of private equity in dentistry, private equity in hematology, private equity in cardiology. So you see that private equity is specializing in a bunch of activities which are very specific, and we see how all of this sort of coordinates when we think about the hospitals in a few minutes. We have biomed, we have medtech, we have commercialized payment. So the two things that we're covering are one to some extent. That's what we have. And I'm not going to do much. So you want to leave now? No. So how big a deal? Well, when you look at the numbers, wow, it's a lot of money, right? That sounds big, not really. 1.8% of health expenditures in high-income countries. But a lot of noise. A lot of noise that we have to think about. So that's the kind of money we think about. The trick is, that's how much money you make. And it's, it's a lot higher than we can make in other places. It's quite interesting because it's one of the private equity companies actually reported data. So it's probably lower on. Some estimates on Europe, they're larger than 30%, but a big reason is given. Actually, that's why the reason as well. Yeah.
So is it because you have too little access or too much monopoly power exposed?
So you see where the monopoly power functions. Yeah. I'll talk about claim scaling in a second, and you'll see why it applies solutions there. But it's very similar to what I've seen in my sector. I mean, when you have private companies coming into the picture, when we can't talk about it now, and so I don't have to talk so much about it at the end. Let me just speak an anecdote, and then you can think about it. So I was working for water privatization in Uruguay, small country, 3 million people. You have 4 regions where there's money to be made by the water companies. And one in the center of the country where there's no money. Center of the country, farmers, 2 farmers, I mean, basically their water services are being paid by residential consumers in the 4 locations. I mean, there's one place where rich farmers also, but 3 locations which were paid for the center. When they tried to package this thing in order to be able to think about getting private money, private sector was only interested in the for-profit centers. So we were asked to think about these sort of issues for the government to provide, and the evidence was they could sell the money. They could sell, sorry, the 4 locations. Montevideo is 1 million people, it's a third of the population. But the fiscal cost of the sector will explode. Because all the financing sources, the cross subsidies that you had from the profit centers actually were basically disappearing in the pockets of the investors. Some of it was going back to the state as taxes. The taxes were going to the Ministry of Finance, not to the Ministry of Infrastructure. And so the funding of the maintenance of assets in the areas where you had about 50% of the population was becoming a problem. That's what we call economic spring skin. So they cream skin, basically the high profit location, they would pick up and the rest they don't want. But if you think about it at a sector level, as I was saying earlier, you anticipate this kind of concern. When you think about this at the deal level, you totally ignore the fiscal consequences of managing a sector, where you do have opportunities for consuming. And the negotiation with the private companies, I mean, I'm still working in Africa on some things. And the big deal is in the last 4 years in West Africa, we've only had 4 deals with private equity companies because the negotiation was such that they only wanted to have very specific terms. When Mali privatized water companies, 2 years back already, that was the rural areas didn't have their own money, so the fiscal cost of the rural area exploded. It's not just rural area. So think about it when you think about that. It's super sexy to attract private money for very specific activities, but what's the consequence for the other? I mean, I think in economics, we often think about these things in general equilibrium, right? So you have to look at the interaction between all of the actors. This is quite relevant even when you look within the sector. The interactions matter a lot. So just a few numbers that you have a sense with, you look at a number of deals globally, well, it's not huge numbers, but they're not very significant amounts. And you see that North America is where the action is, and Asia Pacific comes close to that. When you look at the deals by sector, well, these dudes are big in Europe and Asia. And North America, that's where my sample comes from. And in North America, my sample comes from, I do have a lot of activity in the provider and related services. In Europe, if you look at the volume versus the value, it's a lot of money, but it's not that much money either. So remember, in a second, that's what it means for Europe, for instance. So we work with a sample of 20 countries for which I have all of the data. This is with Abby's, with my colleague who works on this kind of stuff. So we look at the evolution, if you want. It's not accelerating significantly, but moving relatively stable. And if you look at Belgium, it's 2.42%, 2.6%, but it's nothing in hospitals. And again, one of the things that's incredibly frustrating is trying to look for data in the sector. So you have, you have PitchBook that comes up with a very nice database, but when you're trying to do policy design, that kind of data is not useful. Very useful to think about returns, to take a financial perspective, but to do policy design, to look at incidents and stuff like that, you don't have data. It's not being collected. So that's one issue that's quite challenging. That maybe it's interesting for the future.
And who are the providers in Europe that's constituted?
The company, the private equity company?
Not the private equity companies, but the businesses. So if it's not profitable, who is it? Only nursing homes?
No.
Those are providers that we're talking about.
I'm not sure I have.
So the provider and related services are the distributors of like biopharma and medtech, or are they like healthcare providers like hospitals, clinics?
In Europe, we have very good healthcare providers, as it's from there, and it's mostly the stuff pharma, medtech, and the bio.
Yeah, the provider even in Europe, here the pink area is still the biggest.
But because they have nursing homes.
Yeah,
It's better
it's
for
only nursing homes, so it's
more
not
than
anymore.
it's more than in Belgium dentistry.
Yeah,
I mean, if you look at, I mean, I don't know if you know that in Belgium, they regulated dentistry, and it has a bunch of implications. And if you look at who is owning the dentist right now, and if you look at the merger and acquisition in healthcare, a lot of the activity in Belgium is dentistry.
Yeah.
And for your eyes and things like that. So you do have I was telling you, it's not just hospital, it's sort of specialty. So you do have that. But it's not significant. I mean, if you look at the numbers in terms of value, I mean, for the investor, it's a big deal, for the sector, it's not a big deal. But it's a big deal for the sector if you think about the loss, I mean, the increased concentration, which is what you're worried about, and the fact that you have people putting out of the market because they can't compete with the large companies. So you see. I am supposed to take the microphone.
Sorry. Payers would be also mutuality,
The payers would also.
for example, pension funds, etc., or healthcare funds.
I don't
So
know.
companies like AXA, whatever, that they have like, they do have healthcare services and they are payers in terms of, I mean, they do healthcare services.
It's a bit tricky. I may end up doing that. In Belgium, I don't know the details because I think there's one book that I got recently that gives you a lot of detail on this issue. But I think all of the countries, the trick, if you remember, I told you there was one of the dimensions, which was administration and the payment system. So it's quite challenging, it's quite a different of the countries. So it's very different. In Spain, for instance, you know that they would enter on the private side.
Yeah.
They wouldn't be much with the public sector because it's a bit the purpose of the game. And it's very difficult to do.
But it's happening, that is true.
It's increasingly happening, but in some regions only where you have PPF.
Yeah.
Okay, so my goal, I mean, again, this is being repetitive, this is my handle to economics approach to teaching. We have, it's predictable. I mean, they aren't there to make money. I mean, these are not sort of general companies who decide to throw away money. I mean, they're in there for the money and what kind of stuff they want. They will multiply more or less the real capital value by about 3 or 4. That's the average that get the daily press report. Within 5 to 7 years, and increasingly it's sort of leaning towards 5 years. That's not. Most of the trade just buy, majority stake in a healthy activity, debit structure, increase profitability, and then they resell it. Okay. The interesting story is the middle one, how they do it. And this is where you can get the PowerPoint after a minute. So how do they do that? Well, obviously, when you want to make more money, you cut costs. That's one way of doing it, right? Either you sell more or you make more. You cut costs. So, cutting costs to improve the use of available resources. That's the efficiency kind of stuff that Brian has been working on. So, you improve efficiency. You do more with what you got, right? What you see is that you have lots of change in technology. One of the things that's good news with private equity is that you get access to new technologies because most public sector has some difficulty getting the right technology soon. Then they can get it that way. Obviously, they play with financial ratios, which is a problem we'll see in a few minutes. But also, they drop some business lines. When you don't make money, you just drop it. But doctor, I need your help. No, sorry, but I have to move on to something else. That's part of the story that comes out. You have redundancy programs. I'll say a few words about that later. When you go to the hospital, you must have noticed that it takes you longer, right? And Belgium doesn't have private equity, but that's because they're using commercialized approaches to management, which are very similar to the one you get from private equity. But that's the kind of stuff. Change staffing. You have changes in staffing. You have changes in pricing, the kind of stuff that you're talking about. And a negotiation with the reimbursement. How do I negotiate with the insurance company, with the state, or with the clients? So I have 3 players that I can play with, and every country does it in a different way. And in Spain or in the US, because you have a highly decentralized decision-making process in the health sector, it can be different across states or regions. So that's in Belgium, I'm sure that if I look at the data of Belgium, I'm claiming different from Wallonia versus. But what's interesting is that you see higher net income per beds, higher operating margins, total margin and total revenue. All of those things are incredibly predictable. And whether you criticize PE or you're in favor of PE, you will see that these numbers come out in very robust. The difference in interpretation between the two sides of the debate is whether it's good news or bad news. But that's it. Okay, but the trick, what's interesting is that again, for those of us who've been teaching economics, right? I mean, you know that every model that we run for is for a given quality, but you also know that quality is adjustment variable. If you want to cut cost, you pay on quality. That's quite easy, right? So that happens a lot. And the trick that bothers me a lot about when I read about this in medicine, as I said, I come from infrastructure, right? So I'm learning about health, those issues. But I find it interesting is that we have lots of people saying this, oh, this is the value-based approach to health management. Okay, let's define value. Let's define value. It cannot just be about private returns. It has to be about social returns also, which I don't see in the debate, unfortunately. These are, I mean, you do have lots of people talking about that, but they are parallel columns. You don't have a lot of intersection between the two. So that's one of the things that we ask you to talk with people working in solutions. And you'll see why it's an important dimension. And this is the other question. I mean, when you do all the restructuring, right, one of the easiest things to think about is consolidating. Because you have lots of economies of scale, scope, and that you can play with, right? And so what you see is that they consolidate across health markets and specialties, that they then do that across regions. There's a big debate, for instance, in the US right now, that you see different states trying to coordinate antitrust policies, state policies, to be able to deal in the same way with the same hospital being managed across the side of the board, basically, in different ways. So that's quite complicated sort of issues. And then the thing that you see is that once they've done the consolidation, they've done it at a regional level, at the product to market level, they can move on to buy the independent strategies. And that should be vicious type of stuff that you see in the competition journals in the US. Super hotly debate, we'll see that in a few minutes also, is that they do that in a very smart way. Small is beautiful. The smaller the acquisitions, the less likely you are to come under scrutiny by the antitrust agency. And so what you see is that you start with a unit that's reasonable size, that start adding stuff, and then you end up with an entity that's going to control the other stuff. And that's where the antitrust can kick in. But it's a bit late because the green scheme has already taken place. And so to go back to that is quite challenging. And it's not an easy decision, right? So that's really the philosophy. So the trick is that if you get into trouble with antitrust, just go away. And that's part of the interesting story on this. But again, this is not just, I mean, one of the things that I want you guys to keep in mind, that it's relevant for Belgium, because it's not just for PE. I think it's an evolution. When I read the papers on the health management, I think it's an evolution that's like they're getting increasingly more commercially oriented with all of the risks that I just mentioned in terms of bias.
But many of these hospitals are close to bankruptcy. So I mean, that's exactly the question you were asking before. Is it a need somehow to at least go part of that way? Even if you did not have PE?
We're not going to talk about that in details here, but it goes to bankruptcy also because you have lots of people who want to share. I mean, how do you pay for public services? You have three options. You pay as a user, you pay as a taxpayer today, or you pay as a taxpayer tomorrow. Doesn't go further than that, right?
Yes, but if the government says I don't want to pay that much,
you end up having rationing until things get better and people start increasing the co-participation, the kind of stuff that we're talking about, in terms of you start paying more, or you start using, and I'll talk about it in a few minutes. I mean, one of the solutions for this kind of stuff is to rethink tariff structures. I mean, you have a lot more creative in electricity or in water, in railway, or in airlines in creating tariff structures that create price discrimination. It's something we were talking about. We know how to do tariff structures, which are highly differentiated, taking back on efficiency, equity concerns, officer constraints, financing constraints. We know how to do that. I don't see anything else.
not even with PE.
Not even with PE, because they don't need to. I mean, they're focused on, if I were advising PEs, I wouldn't want to get into that discussion. I'll get into that discussion. As long as I can free skin, why would I get into that?
No, then they would consider. I'm talking about the alternative to PE to get better efficiency.
No, but your first one, not even with PE, not with PE, but the alternative is to start. I'll talk about a few minutes about that kind of stuff. But think, I mean, if you compare the level of price discrimination that takes place in a sector like telecom or railways or electricity, and you compare it to the degree of price discrimination that you see, principles which are fairly well established, that we have a good set of what's good and what's bad about them, it's very different. Very, very different. But at the same time, you have a political dimension, which is very difficult. In Spain, in Catalonia, when you try to increase the participation, when you go and see a doctor, and to increase by €2, there were demonstrations. So these are the sort of issues that are very difficult. I think part of it is also communication and marketing at the political level.
There's also the management of just healthcare structures. Where the consolidation thing is, a hospital is not managed properly. Just
exactly, that's exactly my point.
Yeah, but it's not about, it's who's the management, and it's never, I mean, a doctor usually can't manage, and there's no one above the doctor. So who's managing it? Who's consolidating it? You look at Belgium, it's not really about Flanders and Wallonia, it's about networks. And so there's like, if you look at the easiest way to look at it, is like EHR, basically a couple, like there's basically 4 major ones, 2 in Flanders, 1 in Brussels, 1 in Wallonia, and then they just like sub-split that. Yeah, but I mean, it's just like, just how do you do the public sector, private sector, regardless of who's owning it, is how do they actually change underneath it? I don't think it's the owner, it's just like, how do you get everyone on board? And the problem currently, my opinion,
That's exactly my point.
Doctors have no interest in fixing the system, and because what you were saying is like sub-financing, structurally sub-finance, the doctors on top of that are the ones receiving the 7% that are missing from the hospital, and are the ones saying like, first of all, I don't want to change, and second, like I'm the one who will be paying for those changes, and third, like you asked me to do some more admin work, which is boring, and I push that to the young, like graduated doctors who don't want to do that either, and who are in the sector. So we actually go to it.
No, that's exactly my point. Some of it needs to be done, and so that's why I'm asking about the normative benchmark. You eluded that when you avoided that.
Because I don't think you have a normative benchmark. We go back to that in a few minutes. I think you need to think about conflict, you need to think about other things like that, which are very difficult. There are no brainers or things that you can do under any type of contract. But there are many other things which are conflict specific. And one of the things I find frustrating is that they import way too many ideas from the US in these sort of issues, and they don't fit the logic of social security system in Spain or in Belgium and in Turkey. And that's the kind of issue that, but again, towards the end, we talk about that. Then we should go through the how much of they charge management fee of 2%, performance fee about 20% of revenue, and others, a bunch of other specific fees. There is a paper by Fanny Poe and a bunch of guys in 2018 that says that when you add up all of fees, about 6% of the total value of the fee. And they sample size not that bad. It's and that's not there. I mean, you also have upfront payment. You have the fact that I value, but you have some of the money I give you. You have to invest in the business and it's earmarked for a few years. So all of these things are there and they're rational from the point of view of the PE. The question is whether we think it's rational from the point of view of society. That's the kind of stuff that we have to answer. But no, the pricing technique that I've looked at, they're pricing for services which are very often very linear. We don't have a lot of margin actually for non-linear pricing approaches, which take into account equity concerns and stuff like that, which I'm more familiar with when I look at this in the context of infrastructure. So to me, as an infrastructure guy looking at health, I find that a bit low. And what's obvious, all of them talk about the fact that they're rebalancing the focus towards high margin activity. So low margin activities don't get as much attention as otherwise we do. The players are predictable, investment funds, pension funds, other type of funds, but also banks, foundation, insurance firms, and rich people also they can go in this country. Generally, most of those guys are well protected from losing more money than they invested. And what I find interesting, again, my data points, the disclosure requirements are not great. You can download my road contracts from the website of the regulator. You can download my electricity contract, generation contract, but you can't download the healthcare contracts. Why? You can get onto the website of the New Zealand, the Australian, and the various state levels of UK water regulator and download the financial model that I've been using. And then you start playing with it. And do it in health. Why? And that's the kind of fair question. I think the interesting part comes from him, and this is what you guys, what Jason was saying. The sort of issue that you think about is that you have a small management team that runs these things in a very operational way. I'll give you one anecdote which I think is interesting. a friend of mine who's a doctor, working in a hospital, and he does research, the very good research, lots of publication, incredible surgeon, and he's a teacher. And when the hospital was acquired by a private equity firm, they told him he's teaching too much, he doesn't bring money. And publication is quite cool, but where's the money? You're a doctor, you've been trained to help people save their lives, but you do that working. It did. But the future lives maybe come from research and maybe come from teaching. But commercial management will undervalue these structures. The margins are not as big in these activities. So that's the kind of setup that that I find interesting to consider. But these guys are guys who manage the operations. So that's part of the problem. The trick is that all of these concerns overlap in specific deals, and part of it sort of starts bringing the kind of concerns that you have. And you have too many people thinking the same way. We don't, owning the same thing, but spreading the investment across activities which are related. You have cross-ownership and ownership issues that get. And that's why basically this debate in the US is quite interesting. They're starting to realize that common ownership and cross-ownership actually. So if you look at if you want to read more about this kind of stuff, these journals are very good at that. It's not a single month that you don't have an article on this. In the last 3 years, more or less. And we're starting to have empirical evidence on general healthcare and hospitals and specialties and stuff like that on personal and for you on the domain that we can look at. But what I find is very difficult to have a good picture because it's incredibly heterogeneous for a bunch of predictable reasons. And I think that part of that is maybe why anybody who tells you that we have simple rules, that we can have a benchmark or a framework, it's lying to you. I think that the heterogeneity is so big that coming up with a single benchmark, a single framework is really good. In the same, just to give you another example, imagine that you have the same electricity generator in Mali and you have in Belgium. The cost of capital for the generator in Belgium will be 5% more or less, 45% today, maybe 6% today. The same one in Mali will be around 18%. It's the same technology, the same sort of stuff, right? So context matters in many ways because risk levels matter because of the consumer, the main consumption basis. So one size does not fit all. I think it's useful to look at the US because in many ways you can think of it as a leading indicator of what could happen here. At least we're learning from them because I was telling him, diplomats say they have a lot of experience. Experience is the name they give to their mistakes. I think the US has a lot of experience, and we can learn from them. And I think we should look at that. It's big. If you look at the numbers of how much the business has been growing, corporate and physician practices have been increasing, almost doubling. And you see about 1 in 3 of all corporate communities don't do that. But it's a good sample size. So if you want to do fancy econometrics and you have access to the data, which is not always easy, you can do something in the US. You can't do anything like that in Europe right now. You don't have the data.
You don't have data, or there's no such things in Europe?
There's 2 minutes. When the data I showed earlier, we have good sample size in Sweden, we have good sample size in Germany, we have good sample size in Spain, in some of the sectors. We have, so we do have, but you don't have a coordinated effort to do data.
Yeah, but also in Belgium, there's no.
No, in Belgium, we don't. If you look about Belgium, we don't want to have response. But
then should we study it, or should we just like there's no way? In my opinion, I'm quite like because I don't trust private interest to manage social infrastructure in general, but specifically healthcare. But my question is, should we to study it? Should we study how they have been doing in the US, or should we like study different ways of how we can manage it to not manage or publicly owned hospitals and just not cut the non.
This is one case in which more is more, not more is less. Okay. I think you have to do both. Because we're at the beginning of the process. You guys are where we were in the 1990s in infrastructure. That's you're learning, you're doing lots of experiments, there's lots of interesting things happening, but you don't know which way you need to go to as much as you do. We don't. And we have partial evidence, but what I find interesting, as you'll see in a few minutes, when you look at what the US has been doing, they give you a checklist of the kind of things you need to think about when you start looking at the experience that you have within your own country. Some of these points on the checklist will be totally relevant because your world is different, but many of them will be quite useful to think about. And again, I mean, if I'm an advisor to a private investor, I will be looking where the money can come from. And if you guys, regulators in your country, don't want to look at some stuff, well, of course, I'm going to should do that way, because that's where the money is going. So it should go over your checklist, and yeah, you're opening the door to think, to try creative, rational. Again, it's rational, but you have plenty of market failures that you want to think about, and that's where regulation is useful. So let me just
a definition question. You said that you had a doubling of the number of corporate-owned physician practices. If I incorporate myself, am I corporate-owned?
I don't know the answer. I don't know the answer. I don't know how the specific definition that they have. I just got this data, but I assume but knowing the US system, your tax status will be. I'll talk a few minutes about the tax status. The Americans are paying a lot of the tax differences that you have for different types of incorporations. So that's why I don't know whether the micro corporations will get into that picture. I just know. So, and you see that, I mean, they're quite organized, right? I mean, you have an association and you have all the big names. You have Blackstone, you have, you have Bain, of course, you have all of these guys who are quite there. If you're bored one night and don't have anything on Netflix, I recommend that you have a look at their annual report. And I think it's incredibly useful to read this kind of stuff because it gets into the minds of the people who are investing. And I'm on the other side of the table, right? So I need to understand what they're doing. So their reports are quite useful to me. 2 trillion in assets that these guys are macro 74 members. And if you look at the business in Europe, it's not as much. We're not talking about the same numbers, but we see the number of players which are predictable as well. And they also have their own association. You'll be able to look at that carefully. But these are the players that you find your recurring. And then I decided to have a look at what's the market size potential. So one of the ways to look at that, I know that you have a bunch of which already have commercial debt, right? So what are the percentage of the debt which are commercial? And you see that the market size is not small. Right? I mean, there is money to be made. There is money to be made. It's cute to look. No, Belgium is quite interesting in terms of these issues. And this is one of the nice sources of data, by the way, for when you start looking for data and this kind of activities. So a few slides now on what I think I learned that may be of interest to you guys when I start looking at this. It's incredibly curious to see the extent to which you have disagreement between you. You really have 2 schools of thought, and they're very vocal, and I think you find some specific articles biased in specific journals and others in other journals. So you do have that kind of stuff. But it's not very different from what you do in economics, right? I mean, it's not unusual, but for the empirical analysis, it's important to recognize that you have those issues. And we have a lot of sort of qualitative surveys. We're starting to have now quantitative surveys that's starting to emerge. We're going to look at the metrics of the kind of stuff that they see. I mean, when you don't know, it's fixed effects. Yeah. I mean, sorry for the technical, but you know, when you do fancy statistical technique, basically you need to account for a lot of stuff, and when you don't know, you aggregate everything into one approach. But that's where the action is. That's where the margins are. This is where the profit centers are. So ignoring the sectoral perspective by just putting around with fixed effect is hilarious to me. Again, maybe that's more than cynical. You know, and getting over so we become more simple. How much experience do you have that experience? And so we have lots of papers with a negative evidence, and we have also lots of papers with incredibly enthusiastic stories about the deals. And it's cool because you see in a few minutes, the stories are in a sense consistent in many ways. What I find frustrating is that a lot of research comes up with correlation analysis. We have very few papers that do serious causality. And when they do causality, they do it on very specific samples, which they don't mention. So yeah, I have a big sample, but your sample may not be representative of the sector, may not be representative of the country. So these sort of issues are not being discussed, which I find quite frustrating. And so I'm worried about that. Pretty worried.
Am I right to infer that you cannot do causal inference given the problems that you were mentioning, self-selection, etc.?
I think you can certainly do a lot better in terms of reducing the risk associated with the limitations to causal inference. And I also think that there are ways of doing experiments that would be experiments. I think this is a sector that doesn't really, I mean, it's interesting because a lot of experiments comes from the health economics sector. But when you look at this kind of industry, you don't have a lot of people have any.
So the evidence that you get is partial, it's about specific context, specific stories. I never have a sector-wide picture. And I told you, remember my Uruguay example? I can sell 3 things, but then I screw up the rest of the country. Why is it not the case that I think about that for the health industry?
So lots of sample biases, and you look at the papers. I mean, I started doing a table in which I was looking at the hospitals they were looking at, the sample size in terms of number of hospitals, number of patients, number of years, and stuff like that. It's quite complicated because they're not consistent across them.
Isn't that the case? The reality. I mean, the reality. Sorry, isn't that the reality of the healthcare sector?
Yeah.
It's like
No,
the reality is that there's I mean, each country has developed its own policy and developed, because they come from the 13th century. I mean,
but the
so
reality is
it's,
also, the reality is also within each country. I mean, there is a lot of room to actually better analyze the causality than we have. It will be very difficult because across countries, I think I did it. I
Yeah.
can understand why it's going to be difficult.
Yeah.
But within countries, look at the US, the big country with a bunch of states.
Yeah.
Look at Europe. I mean, you can think
but
about.
what is I mean, and as you're explaining also context, what is the normative variation, the regulatory variation within the United States, the end also and the funding?
It's a big issue. Like, but we have techniques that we can play with interactions. There are a lot of more. I mean, what I've seen in the publications are very interesting correlation analysis. But when I start looking at the data that I have, I can think about a few things that I can do differently as a nutrition. And that you don't see, and you don't see it in the health. Any other question? Yeah,
Yeah, I don't get all the economic, but
No,
my main question here is, well, if you come from the utilities, public utilities, stuff like electricity, okay, it's a bit difficult. So a bit more difficult maybe than like oil or just pure raw material, but it's fairly simple. Like there's water, electricity, water, sewage. But if you look at healthcare, just looking at internal medicine is already a nightmare because you've got education. Like I'm very, very, very interested in fixing healthcare from the prevention side of things, which is education. And if you put like education, commercial regulation on like food has a huge impact on healthcare. And so if you just like, there's so many biases. For example, Coke being forbidden in primary school in Europe, in Belgium, like 15 years ago, has a direct impact on things goes like on the that is a big bias that is very difficult to get out of.
Yeah, two answers. One, the nasty one is it's not because it's difficult that we shouldn't do it.
No, definitely.
And the second one is I think you're underestimating the challenges we face when we deal with the rate. Electricity is not easy. Water is a pain in the butt because you have tons of technologies to do the stuff, and the way that's even more. So I don't have a detailed vision on the health sector, but I can tell you that lots of stuff that we've done in very complicated issues, we did for it, and we developed a lot of activities. But you're right, lots of things we weren't able to measure, and I don't expect us to be able to measure everything in the health sector. But we have enough evidence to ask good questions.
Yeah.
And at the end, I mean, you're going to have a regulator that says, based on no information, this is the right thing. Yeah. But the alternative is to say, let's not talk about that. Yeah, I don't think it's a good idea.
So even if it's very difficult, the bar of what we can do or what we can collect, the data we can collect is still quite higher than what we actually currently collect.
And at the very end, if we have the time, I'll talk about that, about data. But I think in my industry, when you sign a contract, you have an annex that looks at the data requirements.
which are not just engineering requirements, and it used to be the case. But when I privatized, I turned on the light and I switch off the light in the same way. But the ownership has changed incredible, and the whole incentive structure is one. So my engineers will see the same indicators, but the economists and the financial people will see a very different picture. Okay. Great. Different multiples, and I mean the outcomes indicator you will see the distribution. And by the way, input indicators are interesting. Why input indicators are useful? Because how many nurses you have per doctor? How many assistants you have per nurse? I mean, all these ratios are part of the ratios people think about. So again, he's right. We don't have an easy, simple diagnostic, but does that mean we shouldn't be doing it? I have a strong view on this. So to understand, I mean, the truth is that we have enough evidence that's growing. With all of its bias, with all the difficulties, and you do see actually people right now starting doing interesting meta-analysis, which are getting into the story. But what I find interesting is that this story, when you read in between the lines, it tells you not just something about the impact of deciding, the impact of deciding to bet on private equity, but it also tells you something about implicitly about the fact that the state hasn't anticipated something. So the policy failures actually emerge. You have to read in between the lines, but the checklist that I've done at the end comes not from specific statements, but from me reading basically in between the lines. Being wrong, but you get to this. But I do find a set of recurring policy concerns. I mean, that's quite interesting. And what makes me super happy is in the last couple of years, is that you see a bunch of people sort of thinking, what if we try this? What if we try that? What if, I mean, so you start having a sense of what are the possible solutions and what are the sort of concerns that people may want to think about. But what I find sad is that it's always in the concluding session, right? They don't have simulations. They don't try to do the modeling to try to get into the issues, but at least we have to manage. So we're getting there. And as I said, I mean, this research lasts 2 or 3 years that I've growing up. So these are the main effects that you can see being covered in these papers. Talk about fiscal effects, which is my concern for the sector. I talk about market size effect, which is my concern for competition policy and stuff like that. Quality effects, which is really what most of the medical profession thinks about a lot. You have social effects, which is what the people should be thinking about. And you have labor market effects, which are quite synonyms. So the fiscal effect is that we're using for subsidy, right? When you cream scheme and you have the profit center which can't pay anymore for the rest, we're using for subsidy. So that has fiscal implications. And this is what we should only invest anymore in rural areas. Who takes care of the rural areas? The state would take care of that? Yeah, but that's what's happening in France. We have made up this kind of results. And basically that market size effect, as we've already talked about a little bit, right? We have increasing market concentration in some activities in the region. In quality, you have the two stories. I can have too much or too little quality, the two sides, depending on which indicator. And of course, if you're in favor, you pick one side of the story, and if you're against it, you pick the other side. But you have few people that look at the whole story complete. What's interesting on quality is a big stuff on narrative focuses on innovation, which you guys are interested in. But yeah, you do get innovation, but at what cost? So let's think about these sort of issues. To me, the big social impact is that we have lost the universal coverage. But that is one of the big things that I've said in a few minutes. Healthcare is supposed to offer universal coverage. Everybody is supposed to be able to get healthcare. But if you don't pay attention to that, you're losing it. And you're losing it in a tricky way. It's not that I say we don't do that, but we do it when we have the money, when we have the time, when we have this. That's an issue that I've gone through. And the alternative also, by the way, is that if you invest so much innovation, you have so fancy technologies become unaffordable. And labor market is a bit complicated. We see a bunch of changes in the ratio of positions that they were known. We see a change in the ratio of staffing composition, and we see wage stagnations for the lower qualified side. So that's kind of evidence that people do have. So things are happening across all of these dimensions: fiscal, market size, quality, social, and labor. And these are just examples, right? You can have tons of other examples that you can when you read the papers. But no, what I find difficult is that I'm looking for a sense that I can at least do what you guys are doing, think about theory and see whether theory can help me, yes or no, and then try to check whether
theory matches delivery when you look at evidence? And the answer is yes. Prices tend to be higher, quality tend to be less predictable, market increases, and coverage becomes more selective.
Less predictable on average or more variable in the sense
Less
of
predictable
quality
on
research, but with more discrimination.
But yeah, it's not actually the discrimination. Yeah, like that, I mean, we talked about steaming and stuff like that, so we did more of the issues which have been addressed already. And I'll say a few words about when I look at cost accounting for the hospitals in which I could dig into the balance sheet. I looked at the cost accounting data, and the cost accounting data tells you lots of interesting stories about how they manage, and you can see how where they cut and where they happen. So that changed quite a lot actually.
So if you say what's the quality tends to be less predictable, but the value of the services, which I would say is the difference between the added value minus the cost of the service, is like consistently lower.
The quality is less predictable because you have a range of activities for which you have some activities which are predictable, some activities where you have an increase, some activities where you have a lower supply.
If we look at the two, one is possibility of loss of quality, and the
Yeah.
second one is more expensive quality.
Yeah, but it's not the same activity.
Yeah, but consistently across different sectors, the prices would be higher for the low cost. So for the same, to get treated,
No,
you have the same amount of money, you know that if there's more PE involved, you'll be in less heaven.
I think, I mean, it really, not going to get into technical details, but in many ways it depends on elasticity of demand. I mean, you can have services for which you have very low elasticity of demand, for which service quality is deteriorated, simply because they don't have actually nurses, there's no doctors, we have to wait for a long time. But the patients actually need the service. So you have low slightly, but they're stuck on it. So when you look at the evidence of an impact, you have a long-term impact in terms of deterioration of the service.
Yeah.
But on the other side, I mean, the other one is you have more expensive quality and better technology and more qualified staffing, stuff like that. But the trick is that who gets the service? So you do have lots of improvements, but not everybody can get the service.
So for the same amount of money,
Yeah.
the quality, regardless of across the board, the quality decreases.
No, the quality across the board, but it's not useful information. And it's useful information but it's partial information. So if I said it's partial information, but you want to get at the state. So if I'm a regulator, one of the things I want to know is the opinion.
When should I use?
And that's where the introduction is, right? So looking at the big picture is useful because to get a sense of that strong. But with that's my argument looking at the sector level. But if you look at the sector level and you try to make a policy decision around that, you need to get into detail.
But can't you just push back this argument towards the PE lobby, just like, hey, you want to get involved in this because there's like 27%.
But that's what
like just but you're like in general, your youth getting involved will decrease the quality of our services.
you're forcing me to tell you the things ahead of time. So yeah, that is what's happening. So in the water sector right now, if you look in the last 3 or 4 years, the PhD students here, Canada, had one of the chapters that look at the extent to which the fact that when private equity entered the ownership of water companies in the UK, you saw deterioration in terms of the investment levels.
Yeah.
So this is one of the things. If you look at the media in the UK, water pollution has exploded because they didn't invent in maintenance. Today, the regulator is negotiating with them 2 things. One is that including now explicit timelines on investment requirements, and 2, the suspending the dividend payments for some activities. So, but they privatized a long time ago. And but it's only happening right now because now we start having evidence. When we did the fees, when we started the fees 5 years ago, we didn't have data on water pollution to match against the activities of each one of the water companies. We just didn't. And it's the same sort of stuff that you have in the health sector. So producing the data is something that should not be in.
It's 1:25. If you want not to answer my question, feel free. But I hear 2 things. First, doctors can't manage, as you said. So let me bring in a manager, but not being private. And then let me have a second step, which is let me make these managers more private thinking, which is key because you gave examples, the Déserts Médicaux in France, You gave as an example the difficulty in Catalonia to make even elementary payments and all. So you try to rationalize, you will go part of the way here. So what is the part which is just better management, just to maintain financial balance? And what is the part which is greediness and cream skimming?
Okay, the bottom, this is not 5 minutes answer.
No, that's why I'm saying, if you prefer not to answer now.
I will give you an answer. I can tell you what the cost of capital should be for industry.
Yes.
And I can compare it to the rate of return of company. If the rate of return is brutally high, like 27%, as it was higher than 50%. Even if I include the risk premium, it's never going to get it.
When you have an experiment, another experiment, when you rationalize management, so you remove the doctor and you put managers, what do you observe?
As I said, I haven't seen that experiment, and what I suspect is that you have rationing and activities like teaching and research, because the horizon is different. I have 27% return in this sector. Very low, and I know
Cream skimming is obvious.
if you give me one, you will speak in 1 second, you will see what the comes. So I just wanted to touch you think about the diversity of outcomes indicators. I'll go fast because I'm only halfway through what I want to go through. But you see, you have tons of indicators, but not a single paper looks at the same ones. So that's part of the problem. How do I get a big picture? If everybody has a focus on a different type of dimension. And it's, you know, it's quite interesting, but I mean, we're mentioning the management techniques, and being studied. You know, this is being studied by accountants. The journals of accounting actually starting to look at for the hospital industry. So there are issues which have been identified by different types of specialties. So it's quite interesting. And this is just me reading paper, right? And I'm not a field expert. I'm just wondering whether the healthcare specialists will come up with much on the list. And the whole thing has an ideology is everywhere. And this kind of stuff. And I think it's very difficult. And you have lobbies on the one side themselves, the two lobbies in Europe and the US. I mean, they're very vocal, they have tons of money, and they can do lots of stuff that you and I cannot do. But at the same time, you know, it's interesting because you have all those things which lead to tons of anecdotes, and then you can start putting around with information. Again, it's quite predictable. I've talked about that. I know what pro PE will say, and I know what people against me will say. And I know where to get data. If I get evidence, if I want to say one story, another one. But in my view, that we have a much stronger case now than I thought we would have in this sector for more enterprising decisions. And I certainly think we need to look a lot more at the sector level and to try to look jointly at all of the stakeholders. I mean, incomplete to only look at private equity or to look at the patients or to look at the fiscal. I mean, it's generally something that we need to look at. And part of the story is what you were raising, right? I mean, this is an incredibly highly political sector. No. So thinking about these sort of issues are not straightforward. But again, unless we look at the sector level as a whole, we don't understand enough. But as a financial practice group, I don't actually know this, but this is an incredibly highly leveraged industry where the private equity comes in. These guys come with very little cash. They go on the market. In the last few years, interest rates were incredibly low. But when you do leverage, you increase your sales, you increase lots of stuff which you can do, right? And you don't take any risk. You don't take any risk. And this is something, again, in Australia, just to give you an example, you can do as much as you want in the electricity and the water sector, but when they calculate your cost of capital, it's calculated on 60% of leverage, even if you have 80 or 90%. I'm going to compute it on a different type. So the regulator can decide to do it in a different way if you want. So this is the aspect that you can think about. So you have a strong increase, in leverage, also sort of hides triggers that you have to face. Why? Well, do I borrow for 3 years, or 5 years, or 10 years? I mean, in industry, in which the asset life is quite long. So how do I manage that? And right now, for instance, interest rates are going up, right? What's the implication? I have the same problem in construction, but looking at the term structure of your debt in the sector is something that I haven't seen in any one of the papers. In my business, it's something we look at. You talk to Matthias and he will tell you about, at the macro levels, it's something you start thinking about. So you have all of those things which are happening, and we have operational change in your operational expenditure, changes the timing, the level, the type of capital expenditure. You have lots of things which are happening, which are not being looked at simply because people have different specialties, and you don't have many regulators in those sort of issues. And again, part of the story is that you need to keep in mind that when you're working on health, you have a social story that happens. My discount rate in infrastructure and health is different from the discount rate that you have in private business. It's not the same, just not the same. So we have lots of things like this that you can think of. I mean, if we look at the contracts that I've been able to look at, tell you that you don't have a very clear assessment of the investment obligation, too much margin maybe. You have, as I said, emerging common ownership issues. You have I look at the PE deal, but I don't know where that specific deal comes from. I know it's part of the story, it's part of the sector story, or is it something which is completely independent? And did I have to unbundle to be able to come up with a deal, which means that I have to hide some activities, some assets, something like that on the side in order to be able to attract the deal? What are the implications of that? This is something we do when we do a sector reform in infrastructure, for instance. So it does have a brutal impact on the financing picture that you cannot ignore very easily. So my point is that all of this kind of stuff brings for me a rethink of the way regulation and competition policy are being looked at when we look at that. And I'm not the only one to think about these sort of issues. This is an emerging agenda in the US. In ICANN, for instance, for site in Europe, have been looking at that. Australia has the same type of debate. So it's an issue. These guys are worrying about these sort of issues. In the US, at the Congress, they invited Gaylor to talk about these sort of issues sometime back already. And when you look at the statement, it's quite, it's quite solid and fair, I think, in many ways. But what I like the most, of course, because of my bias, is that many of these debates focus on the social dimension. Winners and losers, right? And then anytime you do quality analysis, you want to know, you just want to know about the winners. You not only want to know about the winners, but you want to know what the losers are, and can you compensate them or not? And the social concerns these guys are talking about are affordability, access issues, and related capital issues. So these are the three dimensions. I'm not going to talk much more about these sort of issues, but you have higher costs in getting to patients than expected. We have fancy, very fancy technologies, but if they become affordable, what do you do? Right? And you have a bunch of ethical issues, which is sort of when I talk to doctors, they still emphasize a lot that they're saving lives, and this is what matters. And so, do we take that into account or not? So these are debates which are quite super interesting, and I'm doing another survey to learn on ethics in health, and I find it incredible how different it is from health ethics and economics. I'm curious to look at this situation. So these questions to me are reasonable questions. Should competition or agencies account for ethics, for instance, or things like this? And before you answer, you think about the answer to those questions. Remember, when you look at the commitments, if you want, and things like this, when you have strong commitment to universal health coverage. And you want to do lots of things like this, which seem to make sense that you want to have accessible and affordable services to all citizens. How we can remember that? The US competition agency is saying not really. Not really. And you have a bunch of papers like look at just orphan pathologies and rural areas and low margin activities. It's quite interesting because this guy is super pro PE. But it does have in some of his papers evidence that you could have exclusions. So it's quite cool to look at this kind of stuff. And the point is that all of this evidence that we should be thinking ex ante about specifying the mandates to protect the poor. If we don't do it ex ante, we don't just give ourselves the tools, we won't do it. So this is something that I think is quite important. And in my utility sectors in the contracts, you have the universal service obligation. You guys know what universal service obligations are? So when you pay for electricity, in your days when you used to pay for telecom, when you pay a little part of your fee is to cover the expenses needed to cover rural areas where the cost of delivering services are higher than in your city. That kind of stuff is explicit in my sector. Looking in, I didn't find it as clearly, and it's there, frankly, in some of the papers. But it's something when I look at a contract, I certainly will look at it.
Again, this is even when you have these obligations, this doesn't work. Huh? There was Octaplus, this energy provider, which was present in Brussels, They very well anticipated, they were very good at that, to anticipate that the non-payments would increase with the crisis, and they withdrew from Brussels. So it's exactly a way, an example in electricity with explicit obligations. If you can choose your geography.
The contract was fully written.
No,
Because
it's a contract separate contract for each region.
Yeah. But that's part of the problem, is that you have different types of contracts, you have no coordination. Remember I told you about coordination for states, that's the kind of you want to think about. And think about how nasty I want to be. I think the arrogance in Europe, in terms of what they can learn from the experience of regulation of other regions where these things is just amazing. I mean, the way we write contracts in developing countries in many regulations has been designed in a very different way. The way they manage the Greek crisis, they took them 3 years to decide that they had to do a haircut, which we have been doing very well. Light quantitative monitoring, as I said, I mean, look for data, keep looking, and you can look until you retire. Because unless you do one thing that you could do actually, is to have surveys. That you can, but you need the money. But she has the money.
No.
I'll put in the contract.
All the ones on my.
But the point is that all of those things, and can somebody define to me what affordability means in that? I can do it in electricity. 10%. You spend more than 10% of your electricity, of your bill on electricity, you consider to be affordable. The United Nations in the 70s decided it was more than 5% of your income for water. You consider correlation is very high. It's not a 1-for-1, but it's very high. In transport, we have equivalent numbers. Who has it for affordability? We have something for crisis situation in health. Long time, long disease, or lasting disease. But what's the rule of thumb? That's an interesting point, isn't it?
I've read that if you were socially optimum, given how much you want to pay to be in good health, that's right, it would be 30% of your income going to healthcare. 30.
And you live in the street, of course, because I mean that's just.
I know, but in terms of willingness to pay, when you extrapolate willingness to pay in case of crisis, that's what you get.
The European, one of the European is very nice at the table, like on how much people in business household service, how much people are actually spending, and how much is being subsidized. They match that against the expenditure. And you see the financing by the state is very, very high. But when you look at the investment requirements and you look at the matching operating expenditures that you would have to have, they're not money. It's only comes. So it's a lot, but yeah, the aging population that lives longer and that's a lot more addicted to healthcare than it used to be. So the three combinations, so it's more and more. They all read these theorems and the axioms, nunciation, more and more and more. Okay. Lots of paper talk about these sort of issues. If you look at the list, if you want to read about that, but you also have a number of papers who are sort of mentioning that you do have social concerns because the bargaining power of some of the actors are not good. So the poor don't bargain, the workers don't bargain, one of those things. So these papers are quite interesting at that level. And so this would be one reason why you want to think about competition policy and considering social concern as part of the agenda. But then you have a bunch of sort of more standard classical competition policy experts who are sort of world authorities who will be pushing papers saying, no, competition should just be about efficiency, never about equity. And then you have people like Matthias and Thibaut who are saying, yeah, it's more complicated than that. And you're right, and it's more complicated, but you want to think about these sort of issues. I think ignoring social dimension, the debate is open. So,
what is efficiency if it doesn't take into account equity in healthcare?
it's a different criteria. In policy analysis, you work with efficiency, equity, financial viability, fiscal viability, administrative feasibility, political stability, and accountability. So in quality analysis,
yeah, but specifically because we don't have like a benchmark for healthcare for what is like healthcare. I mean, the amount of money that we pay for healthcare is what is being like having a successful healthcare system. Is
I can talk to you about after the presentation, and that's the arguments of concentrate they use even by working about But it's not, you don't have a rule of thumb that you can say, this is what I should be looking at. It's too long to explain, maybe just look at it. So I think a lot of what I have here already told you, I can do better on the social dimension, I can do better on the contract design, I can do better on regulation, and I can certainly sort of look at what has been done elsewhere. You don't have to reinvent the wheel in many ways, right? And I think there's a lot that can be done at that level. I don't think we have a simple agenda. But let me just mention a few things that I think make sense to think about. I think being clear about the goal, being clear about the mandate, social concerns, the tools, and expose and evaluation. How much time left do I have? No, I have to think that. I don't try because 115 minutes.
Can I ask a very naive question? How strong is the lobbying group in infrastructure compared to that in the healthcare sector?
I think it's maybe less transparent. I think, but it's. I'm thinking about it because I don't want to give anecdotes which would be getting into legal trouble. But I can tell you that the lobbies. I was sitting at a desk, sort of organizing restructuring of activities. And I would have companies calling me. I would get invited to a very 5-star hotel to go and visit their new factories. So, lobbies will come in different shapes and colors, but they're all there.
Sorry, may I just add something to
That's a lobby question?
Hi, sorry. I'm a former lobbyist here in Brussels for a different sector, nutrition, food supplements, cosmetics. But in the last 10 years, I was a compliance officer and focusing on medical education issues. And now I'm handling ethics and compliance in healthcare, and especially the financial interactions between industry and the healthcare professionals. What changed over the last 10 years, and I'm also serving non-for-profit association for full disclosure. What is interesting is that industry has self-regulated. So the pharmaceutical industry and the medical technology industry, they have pulled out code of ethics when it comes to conflict of interest, transparency, disclosure, a lot of things that are actually addressing those issues. And I basically was in charge of projects that were tackling what you are allowed to do, but what you should be doing in terms of ethical requirements. So I think, this 5-star thing is like an old story. It should be, but clearly what industry has put in place is actually new, and it's not topped by any other sector, which is bringing hope, I think, to that discussion, at least, because you've got the law, you've got the regulatory requirements, but you've got the ethical and compliance requirements, which are coming to the forefront. And I think it brings hope to this discussion, seriously.
And you look, am I supposed to be there for the microphone? Have you looked at the budget allocated to supervised compliance? The easiest way to cheat and to deliver non-compliance is to not monitor. Easiest way not to monitor is not to allocate any money to monitor.
Yes.
Would love to see the budget allocated to compliance for the kind of self-regulated commitments that are being made by the industry.
It's not, you can see it in annual report by manufacturers. I'm talking
because that's a world standard everything. If I look at France, which you know so well, you know that the food is underfunded at that level. We wouldn't have the problems that we have in a regular basis. Same thing in history. And in health and discovery. I'm going to try to back.
Both sides are, I mean, the question this has evolved. We compare to 20 years ago, 15 years ago, this is take for sure. The question is to what extent and what, you know, the question is how it has also changed the way it is done. I mean, you don't go with the bag to the doctor's office, but there's different ways to do it. And there's also, which I think is different, is the regulatory part, the influence on the regulations. Not so much nowadays on the part of the doctors, of the buyers or the prescribers, etc., but it's the effort that is being done on the regulatory part, which is a lot. So if that,
I don't like the word a lot.
well, that's a lot of, I mean, yeah, sure. It's a percentage that is very important. I would say, I don't know the numbers. What I could
That's
do,
fine.
yeah, that's for
That's
sure.
fine.
And I agree with you 100%. I
Chico.
think it's,
Chico.
yeah.
I mean, I want to see that it was one of those, because
Yeah,
again,
sure.
again, I'm 66 years old.
Yeah.
And most of the crises that I've seen, the
Yeah.
situation in which it boils down to numbers.
Yeah, sure.
And politicians will be very good at underfunding activities which are crucial. So we look good in the picture, look, we inaugurated this thing, but who maintains it? You look at the number of roads for which you make a commitment, for the rate of return of 25 years or 30 years of maintenance, and you maintain it to the next election. And you do rehabilitation when the election comes up. So that's the kind of stuff that you want to think of. So I'm not going to get
You don't have to rush. We are having a discussion already now. Those online can of course ask questions, but you still have 13 minutes to go. Since the discussion is already happening, it's okay.
Okay, so these are 5 things that I want to talk about because I know something about them, but other things probably that should be in the list that most of, I mean, some of you guys would want to add, but that's for your next presentation. You guys go to the seminar and present it. Your thing is what name? One of the things that I found interesting again when I look at these sort of issues, it bothers me because I want to go to the point. I'm not done with that.
You have 12 minutes.
Okay, look at my sector. We have sort of competition in energy, and we look at the ownership in the energy sector. Okay, the electricity companies have all signed agreements to make a bunch of things in terms of the environment. But on the board of each one of them, which are supposed to be competing with each other and have signed a joint agreement, you have BlackRock, you have the Norwegian funds, you have all these private equity companies which are sitting with less than 5% on the board, but that's it at the board. And they haven't signed the agreement. They're minority owners who have a voice, and their voice is being heard. This is what, if you look at the UK story, which is the best documented in the last 3 years, this has been an issue. And so that's why I'm arguing that common ownership and things like that, that looks at the degree of competition. Focus cheap. Looking at the details is a major issue, and it's certainly an issue in the pharma industry. I mean, lots of papers showing that we have a problem of concentration and that these commitments are difficult because of the owners behind the fix. And which, I mean, again, I'm not an expert on health, but when I start looking at the players in the US, and it's quite cool that these guys are supposed to be competing, but they're all the same things. So not surprising that we're going to have some sort of arrangement so that the price will be good. So let me go back to this here. I need more explicit goals. Again, why do I say that more explicit as compared to what I'm familiar with in my sector? But maybe it's because it's easier. I want to have full coverage of electricity, but I want to have full coverage of capital. But maybe we have more details to think about in health. But again, I'm not a medical specialist, but when I look at these sort of issues, I can come up with ideas to other things that we include in this. And the sort of stuff that I would think about, because I've read all these papers and I would think about when I do my goals, should I have a goal with respect to the fact that it's not just a universal health coverage, but it's specifically affordable health coverage. And then I have to define affordability because I don't have a definition to do. So it's cool on paper, right? I look at all this paper, wow, they thought about it. But okay, at the end of the day, it's when you don't measure, you don't do.
Just as simple as that. The rest is cheap talking. And in real life, everybody goes on to other examples that, you know, access by all entries, agree on credit spending, stuff like that. This comes from the fact that we're thinking way too much in terms of deals, and we've made the same mistake in my career. Now, I think we need to think at the sector level a lot more, and I think a lot of it is, like I said now, way too many broad qualitative statements, so it becomes messy, becomes not very transparent, and I have a problem with that. Moreover, I'm trained by engineers to think in terms of curve charts, right? I look at deadlines. I look at bottlenecks. I look at things like this. That's what I've been thinking about for 25 years of my life. And I don't see that. I don't see it. So these guys are coming in for the next 5 to 6 years, but I'm investing for the next 25 to 30 years. And so what happens after 6 years when they leave? What are the rules doing? That kind of stuff where you can actually write a contract. Yeah. And then you have games which are being played, you know, the games that you have in your wedding. All the stakeholders come and give you big kisses and hugs and I love you. But at the end of the day, where's the beef? And so where, you want me to get it out?
No.
Okay. So what's key to that is to understand that different players have different goals and stuff like that. I'm not boring. I knew it was the PE wants to maximize it. I mean, every one of them has a different objective. How do I reconcile it? And when you look at the papers written by different types of stakeholders, it's funny because you see their underlying goals. But you don't have a full paper that says how these things get reconciled. So that's quite interesting to look at. So I want to have a much, you know, things, and we don't see that. So I need that to be able to advise. I mean, that's where the trade-offs come from. I can't do everything. I will not do this because I have to pay for education, I have to pay for roads, I have to pay for other things, right? So I have trade-offs. But how do I decide on my trade-offs? And so this is why I think the sector may want to consider having different types of set of regulatory tools. And part of the story is to have a clear vision. Who are the people you talk to in health? When you have a specialist in pharma, you have a specialist in medtech, you have left and but the broad picture I found difficult to come across. You have these papers which are very useful in terms of giving you a big picture, but it's very generic. And something that brings together, when you want to, everything you look at, you want to look from top down and from bottom up, right? So you have a fair volume of research on top down. You have a lot of research on the bottom, but you don't have a return to the top from the bottom. And that's something that maybe somebody needs to have a mandate to do this kind of stuff, which is taking research and division of labors in many ways. And part of it will have to go through enhanced data, I mean, transparency, disclosure requirements. We don't have this industry. I have more of that in infrastructure than you guys have in health in this sense. So all the blah blah that goes together, we can create a nature. And of course, you know that I think we can do a lot better on the social side. There's lots of things that we can think about this. Some of it has to do with the return. Am I willing to unbundle enough to be able to have specific private needs? My Uruguay example, right? Am I willing to go that way? If I know I won't be able to afford the subsidies to the rural areas, am I willing to do that? Or I need to say, man, I could have more private money, but the cost of that is excluding the virtual population. Do I want to do that? So but I can do simulations and I can do different types of packaging. I can have cross subsidies, you know, within some regions. I can have these kind of, we can do that. We have the tool, we have papers which have been written that you can download an Excel spreadsheet and does it for you. So it's surprising, right? Which includes, by the way, defining service obligations of all the stakeholders and a bunch of things like that. So it's complicated because it may be that you have what these guys in economics call participation constraints. If you have too many rooms, right? Maybe they say, well, I don't need you. I don't want to be there. But that's something that you want to think about. Again, I don't see that. I see lots of super cool stories on the case study, and I have 4 minutes to what I'm skimming to wrap up this thing. So we want to have the tools, and we don't. As I said, I mean, I try to download tools to be able to look at What if I want to do simulations? What if I want to get a sense of what the thing happening? You can do it for my sectors, you can do it for water, you can do it for electricity, you can actually do it for telecoms, if you want. I can't do it for health. I'm a citizen X, and I want to know, I want to use my brain and use it. Not easy. Okay, so that's part of the plot that I want, but I do need to be able to do this and to find solutions, incentives, like free scheming and stuff like that. Unless I don't measure things, I'm not sure I'll be able to deliver. And we always deliver for a bunch of no, for the show. Then do we deliver for the needs? That's one question you want to ask us. But certainly you want to do it with the transparency of everything, the choice, the trade. So that's that means that you have to put in place specific reporting requirements, which are not bad in health, but they have a strong bias towards health-related issues, not the financials. And certainly not on the social. So that's part of the problem. Like, there's a long list of things that I could think of that I was reading in terms of information list. I don't have an exhaustive list, but if you want to go through, you're welcome to do it. Now, the risk is you don't want to do too much either. The regulator in the UK, the water regulator, and I was in my previous job, issued so many requirements from the water company that every company had to have 4 workers filling in the forms. And I printed one day, and the list of requirements was a pile like this. That you don't, I mean, it's too costly and people will pay for it. So I think also we need to think more specifically about social rates of returns, which means doing ex-ante evaluation and ex-post evaluation on most systematic basis. The question is who should do that and how do we do that? Who is mandated to do that? Who should be mandated? You guys? Of course not.
How can do it?
Yeah. And I think it really without the conflict of interest, which is really why it was. Definitely, I mean, ethics is part of the event. So I think practice is a lot more challenging than theory than it is. Certainly, if you work on private equity. I think we have now solid evidence based on the US experience and other sectors' experience in Europe that there is a case for better regulation competition. Simply adding more regulation is not a good idea. I think you want to be more pragmatic in that. I think also that we need more empirical research on possible solutions. We have a list of possible solutions, but we don't have a lot of detailed information on how effective these possible solutions are. Is that something you want to think about? And again, if you can research on that, would be a good idea. So, a few no-brainers. There's a lot more stuff to do to work on for people mentioning their language. And we don't have to exactly go through prevention. I think you can think of that. But I think that usually yeah, we've done lots of things in the last 10 years, but I guess if you want to look at the first derivative and you want to do a second derivative, how fast do you do it? And whether you still voila.
So one lesson I draw from, I remember vaguely, maybe Pam can confirm, I think the number 5, 314 was invented, discovered, because you wanted to know how much weight you had when you were putting a rope around it. So you need to know the surface, just having the length of the rope. It was nécessité fait loi, right? And what you're showing is the same thing, right? We need numbers and we will invent sorry?
For your story, it was a canteen.
Well, you'll be in better health to eat it if we have the right numbers. And so that, to me, that's an important lesson. You need to show the needs, otherwise the numbers will not show up. I don't know if there is a last question. So I want to thank everyone throughout the year too, and today Antonio in particular, because this has been, as I said, a very intense year, and we will have a lot more even next year. Thank you.